What I want to do in the next 80 minutes is go through what I think probably 90%, 95% when you throw in the lateral ankle that Emily Vinson will talk on, of the things that you really are going to see and that you're going to really need to know. We have a monthly foot and ankle conference with our surgeons. We used to do it twice a month, and everybody just kind of ran out of time. And we would meet with them regularly and go over MRs, and they would show us what they found arthroscopically or tell us what they found. And it was an enormously good learning exercise, and I'd urge you to talk to your surgeons. And what we found out is they'd say, gee, we didn't know you could see that. And we'd say, well, I didn't realize you needed to see that. And just by talking to them and asking them what do they need, what do they want, it's made a huge difference in the way we do our MRs. And showing them the utility of MR has made a huge difference in them ordering them as well. This article out of Jefferson some years ago showed the effect of foot and ankle MR on their clinical decision making. They had 81 patients that were examined by 4 foot and ankle specialists. Now, we have 3 foot and ankle specialists at Duke. The chair, Jim Nunley, was the former president of the American Foot and Ankle Society. They have 2 to 3 fellows every year dedicated just to foot and ankle. So most orthopedic surgeons are doing some knees, some shoulders, some ankles. These guys are doing just foot and ankle, and they obviously are very experienced and very good at it. And these were 4 foot and ankle specialists as well. After they examined them, came up with a provisional diagnosis, they got an MR and changed their diagnosis in almost half the cases, altered the treatment plan in a third, surgery was canceled in 6%. And empirically, that's about what we felt the utility of MR in our practice is as well. As far as the protocol, it's pretty straightforward. About the only way you can screw it up is by doing foot and ankle. Now, you would never do elbow and wrist, you wouldn't do bilateral knees, and you shouldn't do foot and ankle. Pick which one you want to do and use a small field of view. If you use a larger field of view, the resolution will be so poor that you will miss some things that you shouldn't. It'll be difficult to make the call sometime. We used to say, primarily you want axial imaging, and then you could pick either coronal or sagittal. But every time I had axial and coronal, I found myself wishing I had a sagittal. Every time I had axial and sagittal, I found myself wishing I'd done the coronal. And I think most people now go ahead and bite the bullet. It's a long protocol. It's axial, coronal, and sagittal, some sort of T1 or proton density, and some sort of T2. It doesn't seem to matter. Now, T2, again, I mean fast spin echo T2 with fat suppression. If you prefer, you can do fast stir. There's probably no real need to angle, but some people say as you go down perpendicular to the tibia, your axial images should be like this, and then reorient and go perpendicular to the midfoot like this. And that's okay, nothing wrong with that, but it's probably a waste of time. No one's shown more diagnostic accuracy by just doing contiguous axial cuts versus angle cuts either way. We like to just put them in plantar flexion and do stacked axial images. There's not a problem if you want to angle, but you don't necessarily have to. It's been written that if magic angle is a problem for you and these tendons go down through a 55-degree turn to the relation to the bore of the magnet, so magic angle can be problematic sometimes. If that is a concern, several articles have shown studying them prone will help get rid of that because it decreases that 55-degree turn as they're more plantar flexed. These are 2 images of the same patient. This image on the left looks sharp and crisp, nice fat suppression. Image on the right suffers from signal to noise. Look how granular that is. That's an ugly image. The only difference between these two, these are both fast stir. This is a TI of 150, as we were talking earlier. That's the default TI on most magnets for 1.5. This is a TI of 110. If this is too gray for you, you could go 120, 130, play with it, see what suits you. But you're going to see all the fluid you need to. This is going to be high signal because it's fat suppressed. This will give you uniform fat suppression, and because of the calcaneus curving around here, and certainly in the toes, the uneven anatomic surface often gives you poor fat suppression. This article by Kajowski some years ago talked about a modified stir sequence for use of the rotator cuff. And in this article, he talks about the parameters, the technical parameters, why a short TI stir is superior to the standard stir. It increases the signal to noise. It's a slightly shorter sequence, but it's not enough to save you any time. But if you're interested in finding out why, look at this article. It'll tell you why. I'm going to start with the tendons. one of the primary reasons we were asked to look at the ankle. The anatomy at first is quite daunting if you haven't done a lot of foot and ankle. I think everyone's comfortable with the Achilles back here. And I'll mention the Achilles is the only tendon that's going to be in the sagittal or coronal plane of imaging longitudinally displayed. And the reason I mention that is we've seen a number of examples where people are trying to look, say, at the tibialis anterior or the posterior tib on a sagittal image, and as it runs out of that sagittal plane, it looks like it's tapering off as if it's attenuated and torn. And we've seen them overcall tears just because they're running out of the plane of imaging. The Achilles is the only one you'll see routinely longitudinally displayed. The others, you really got to rely on the axials. The peroneal tendons sit behind the fibula. They're held in place by a strong retinaculum. Then we go over to the medial side and see the flexors, the posterior tib, intimately associated with the flexor digitorum longus, which is half the size of the posterior tib, and that size relationship is important. Then you have the neurovascular bundle, if you will, between the flexor dig and the flexor hallucis. Nothing happens anteriorly. You don't need to waste your time looking up here. The extensors, nothing happens. About twice a year, maybe 3 times a year, we get a requisition that says torn tibialis anterior. They already know it's torn. They're doing the MR to see how big is the gap, because they have to go up and find the ends of the torn tendon that are retracted. So you can look out here all you want. You're not going to see much. It's very low yield. We look at this T1. We've got posterior tib, flexor dig, flexor hallucis. This old mnemonic, which has been around since the days of Galen, Tom, Dick, and Harry. And as quickly as you can say those, you can look at each of these flexors. And I do that on about 3 or 4 of the axial cuts around the tibiotalar joint, because that's typically where they're abnormal. And I'll look at Tom, make sure it's twice as big as Dick, and look at Harry. And for artery, nerve, and vein, any mass in this region, which would represent tarsal tunnel syndrome, which I'll talk about. I like to look at the peroneals and make sure that this muscle belly disappears before the flexor hallucis. The flexor hallucis should have the last muscle belly as you go distally on your axial cuts. If you continue to have muscle belly over here, that's abnormal. It's either a low-lying belly of the brevis or it's an anomalous muscle of peroneus cortis, either of which can be symptomatic and cause lateral ankle pain. Some of the surgeons will go in and resect that muscle belly with resolution of symptoms. Not all believe in that. If you do want to look at the anterior structures, at 12 o'clock is the tibialis anterior. There are still an atlas or 2 out there that have arrows pointing to this as the tibialis anterior. That's the greater saphenous vein. Of all the tendons, pathology only occurs in a few areas. We don't image many Achilles. You probably don't either, because it's such a straightforward clinical diagnosis. It's kind of had a resurgence as more and more surgery is directed at removing, shelling out, if you will, that myxoid degeneration. They'll use ultrasound or MR to see the extent of it. They'll know that it's not a complete tear, that there's tendinosis. Before they go to surgery, they want to know what's the extent. But for complete tears, partial tears, we don't image a lot of Achilles. Tibialis anterior, I told you, we see 2 or 3 a year. They already know it's torn. So that really just leaves these. And the flexor hallucis is torn even less frequently than the tibialis anterior, but it has some associated abnormalities that we'll talk about that make you want to look at the flexor hallucis as well. Primarily, we're looking at the posterior tib and the peroneus longus and brevis. In the Achilles, you're going to look for tendinosis. Now we use, and this is not absolute, and it's never been written, but we use this pretty objectively. If we've got gray signal, whether it's a rotator cuff, whether it's the Achilles, whether it's a posterior tib, but any tendon with gray intermediate signal, that's tendinosis. As Don Resnick was mentioning, it's mixed order mucoid degeneration. If it's got fluid signal on a T2, or if it's attenuated, with or without any signal, if it's thinner than it should be, we use that as a partial tear. It's objective rather than subjective. Some people use severe tendinosis, use the term partial tear. But we typically, when we look at our op reports, have found very good correlation between fluid indicating partial tear and tendinosis being no fluid signal on T2. Complete disruption, that means there's a gap, obviously. And don't forget, don't rely necessarily on the sagittals to look for that gap. You can use them in conjunction with your axials. Retrocalcaneal bursitis, often have a little bit of fluid down here at this interface, but whenever it's like this, you can bet that that's a source of pain. It's almost always associated with abnormality in the Achilles. If you deem this to be fluid, you'd call it a partial tear. If you say, no, that's not fluid signal, it's gray, you'll call that tendinosis. I'd have to see more images and maybe even the axial, but I believe this was called a partial tear. This is an easy call. This is a complete disruption. They knew it was torn. The patient knew it was torn. He described it. They got the MR to see if there was a gap. With a large gap, they said they would probably intervene surgically. Without a gap, they wouldn't need to. And there's no gap. They decided to treat it non-operatively. Now, 10, 15 years ago, it was a real dilemma, very controversial among surgeons, with half of them saying you need to do surgery on all these torn Achilles, the other half saying no, you can treat them without surgery. The downside of doing surgical repair was the anesthetic risk, which now, 10, 15 years later, there's almost no anesthesia risk at all. So that's not an issue. There's a real but small incidence of post-op infection, but it's less than 1%. The risk of not doing surgery is these are usually middle-aged men, women, 40 to 50 years of age, and they have to treat them for 12 weeks in marked plantar flexion. And when they get out of that immobilization, they can't get their motion back. And that can be real debilitating for a 40, 50-year-old. But even worse than that, there's up to 25% incidence of re-rupture at 1 year. Nowadays, most surgeons are adamant that these all need to be fixed. Now, 20 years ago, I knew 2 surgeons who said, no, you got to operate on all these. They tore their Achilles. They opted for conservative care. Tells you where their heart really was. Nowadays, we just had one of our sports medicine docs about 3 years ago tore his Achilles. He didn't even hesitate. He had surgery. The data seems to suspect surgery is the way to go. MR doesn't play a big role. Here's one that's markedly distended, intermediate signal. This is severe tendinosis until you look at the T2 and see that, no, this is fluid signal. This is a high-grade partial tear. You don't have to see a gap. You don't have to see attenuation. This is going to be a high-grade partial tear. An area that we do image a lot is the posterior tibial tendon. A lot going on with the posterior tibial tendon function-wise. It helps maintain the longitudinal arch of the foot. As it comes down behind the medial malleolus, it inserts primarily onto the tubercle of the navicular and then sends strong fibrous bands underneath to the cuneiforms and first 4 metatarsals where it makes up the longitudinal arch. If this stretches or tears, they end up with a flat foot, a painful flat foot. It doesn't have to tear to do that. It can just stretch. Tendinosis can do it. If it does, they'll fix that surgically if it's torn. If it's not torn, they don't have a good result operating just for tendinosis. They'll try to get by without surgery, orthotics and bracing and whatever. But so they get the MR to know, is it torn or not? Is this surgical or not? If they fix this, they often fail because they have to fix the spring ligament or check the spring ligament as well. It's also one of the primary components for maintaining the longitudinal arch. It runs just deep to the posterior tib. And 15 years ago, when we first started looking at the spring ligament, I couldn't have told you where the spring ligament was. I'd never seen one. It'd seen me, but I'd never looked at one. I'm sure many of you are not evaluating the spring ligament. The ankle surgeons nowadays want you to look at the spring ligament. I'll show you how to do that. It's fairly easily done, but it takes a little practice. It runs just deep to the medial collateral ligament, or to the posterior tibial tendon, curves underneath the head of the talus and holds it up like a hammock or a sling. If it fails and the posterior tib fail, and they fix the posterior tib but don't fix the spring, that's a surgical repair that's doomed to fail. Because even the best construct often can't support the arch without having the spring ligament also intact. We'll want to differentiate between tendinosis, partial tear, and complete disruption. Here's a posterior tibial tendon that's got tenosynovitis, which by itself doesn't mean a whole lot because the underlying tendon is abnormal. And here it's just intermediate signal, it's not fluid signal. But the next cut, you can see that the caliber of this tendon is considerably abnormal. It's thinned. And then it goes back to maybe a little bit of enlargement compared to the dig. This makes it a partial tear because it doesn't have that circular boundary intact. Here's one where we just have some tenosynovitis. Now, at the end of the day, after they've been walking, almost all of us will have a little fluid around the flexor tendons. I don't like to see any fluid around the peroneals. I don't always call it tenosynovitis, but it makes me look very carefully at the peroneal tendons. But the flexors often have signal. This is a little bit more than I like to see. And they came in, rule out torn posterior tibial tendon. If I don't see a tear or an abnormality of the tendon, I'll call tenosynovitis. If I have a definite abnormality in the posterior tib, I don't say that there's a partial tear or tear of the posterior tib and tenosynovitis. There's nothing for them to treat on the tenosynovitis. It gets trumped by the pathologic tendon. Well, in this case, the tendon looks pretty good compared to the dig. It's not thin, it's not enlarged, it has no signal in it. But as we go more distally, look how flattened it is. It's thinner than it was. This is a pre-rupture state. This is a partial tear of the posterior tibial tendon. It's attenuated or thinned. Notice the edema in the medial malleolus. Now, you can get edema in the medial malleolus just from tenosynovitis. That's been described. It doesn't really mean a whole lot. But I pointed out because anything reactive in the soft tissues, like tenosynovitis, can cause underlying reactive change in the bone. And keep that in mind when you're looking for osteomyelitis. Everyone wants to say, well, gee, I've got soft tissue infection here and I've got edema in the adjacent bone. It's got to be osteomyelitis. It doesn't have to be. You can get edema in the bone from cellulitis, an adjacent phlegmon, and no cortical break, no osteomyelitis at all. In this case, posterior tib looks okay on T1, but I go to look on T2, Tom, Dick, and Harry, there's no Tom. This is just an empty tendon sheath. It's a complete tear with retraction. Clearly an important diagnosis because this patient's only going to get better if they have surgery. They may choose to put up with the discomfort and disability, but if they're going to get better, they're going to have surgery. How about this one? Tom, Dick, and Harry. I don't see Tom. On the T2s, you can just see a string. And I don't get into, well, there's one little string left. This is a high-grade partial. If it's this tiny, that's a tear. As we go further down, you can see it here, and you can see just a remnant of it here, but there's no posterior tib here. So this is a tear with a gap between maybe here or one cut up and here. And measuring the gap, it's tough to be precise because do you go up to where there was normal tendon, or can you take this little dot of remaining tendon? And we talked to our surgeons about it at conference, and they're not real interested in giving a 3.2 millimeter gap. They want to know, is it 5 millimeters, is it 3? And they're going to look at the MRs. The top surgeons look at their MRs. They do that in the knees, they do it in the shoulders, they do that in the ankle. They don't read them as well as you do, but they're pretty good at the anatomy that they're interested in. Most of them, a T1 and a T2, they think those are thyroid tests. So they're not going to know what you know, but they'll know the anatomy, and then telling them that this is a complete tear with a moderate-sized gap or 2 centimeter gap, you've done your job. How about this one? I've got to Tom, Dick, and Harry, and you can't have a stutter. This is a longitudinal split tear. Longitudinal split tears are significant because they're the same significance to the surgeon as a complete tear with a gap. They're not going to get better on their own. It's felt these never heal. Now, why is that? You know, rotator cuffs are said to never heal on their own. Rotator cuff tears. ACLs never heal on their own. And we've all got exceptions. We've seen some ACL tears that that did heal, but those are reportable. And in fact, we did. Same with posterior tib. Medial collateral ligament, though, Achilles. Achilles with a 5 centimeter gap will heal on its own. The difference seems to be if it's bathed with synovial fluid, there are enough cytokines in there of different types to prevent spontaneous healing. In fact, there are $1 million grants now at the NIH to investigate that, to see if perhaps you could put in some sort of medication into, say, the knee joint to allow the ACL to heal, or the rotator cuff, or the posterior tib. But if it's in a tendon sheath, if it's in a joint, if it's got synovial fluid, it's not going to heal on its own, whereas the medial collateral ligament will. The Achilles will. These split tears are important, though, because, again, they have the same significance as a full thickness tear with a gap. How about this one? Tom, Dick, Harry. Tom, Dick, Harry. Wait a minute, what's happening to Tom here? Tom's completely encased in bone here. And here it is more distally, and then it's gone, and then it reappears. I think you can figure it out that this is an old fracture of the tibia where the posterior tib got trapped and the bone healed around it. He now has no posterior tibial tendon function, and for years he just thought it was all a result of his fracture, and limping around his fracture is not quite right. And this can be tough to see. Now, we don't do MRs on these. You don't either. You do CTs. You do a CT to look at the complex fracture. And our fellows and residents describe every little chunk of bone and cortex that's gone, and the surgeons don't read that stuff. They don't hang your report in the fracture fixation room or in the OR. They take the images. So you can give them just a gross description of the fractures, but remember to use soft tissue windows. Don't fix just on the bones. Here's a bilateral fracture, dislocated the peroneal tendons here. These were dislocated as well. Trapped the posterior tib here, and posterior tib here is trapped. So he trapped both posterior tibs, dislocated peroneal tendons. We see at least one a month of these complex ankle fractures, and I'm sure you do too. And we see at least one a month, however, that has the tendons displaced or entrapped. Important to remember to look for that. Our surgeons told us some years ago that the posterior tibial tendon, when it's torn, is often just the first domino to fall in a cascade of events that'll result in 3 or 4 things that they have to fix on these patients. The posterior tibial tendon helps support the longitudinal arch, and if it tears, the spring ligament is then affected. In this series of 25 patients that we put in AJR with a torn posterior tibial tendon, 92% had the spring ligament abnormal. The subtalar ligaments in the sinus tarsi then are supporting the arch or helping to. Almost 3/4 of them were abnormal. And we tell that they're abnormal by scar tissue replacing the fat in the sinus tarsi. The patient then has a flat foot and starts walking in an awkward fashion, hitting on the medial tubercle of the calcaneus, and a third of them presented with plantar fascia or had plantar fascia. And some of them, this was the presenting complaint. They'd kind of gotten used to these other things. So look for these dominoes falling, starting with the posterior tib, then the spring ligament, then the sinus tarsi, and maybe even the plantar fascia, all 4 things in the same patient. And if you see plantar fascia or sinus tarsi, work back, look at the spring ligament and the torn posterior tib. After we published this, our surgeon, chief of foot and ankle division, said, well, it's not a 90% incidence of torn spring ligament. It's more like 20. It was just at a meeting and somebody published that. And I said, well, we didn't say torn. We said abnormal spring ligament, either thick, thin, or torn. We don't even really know what a torn spring ligament looks like. He says, really, I've got a dozen of them I can give you, and they've had MRs. We did surgery. We should look at that and publish it. One of our fellows, Leon Toy, who's actually here at this meeting, did just that, and I'll show you the results of that shortly. But first, let's look at what the normal spring ligament looks like. Here's a coronal image. Here's the posterior tib, Tom, Dick, and Harry. And Harry, the flexor hallucis, was always be associated with a sustentaculum talus. So if you can find the sustentaculum talus on any view, sagittal, coronal, or axial, you can then go back and find the dig in the posterior tib. Just deep to the posterior tib, coming off initially as part of the deltoid. It's called the tibio-spring ligament up here, where it's part of the deltoid. It then continues on down, and it's not a round ligament. It's a band of tissue. So you'll see it on the next cut forward. And back here it inserts on the sustentaculum talus. Here it is inserted on the sustentaculum. It's this low signal band of tissue holding up, supporting the talus from going in this direction. It's just deep to the posterior tib. And I can't separate it from the posterior tib, and you often can't. But you can see above it, and you can see distal to it. And I called a lot of these tears where it didn't quite go onto the calcaneus, must be a tear, but those aren't tears. It's not a common place for it to tear, although they can. This is some loose collagenous tissue that's often seen as increased signal. If you did a talonavicular arthrogram, which we've done in a few professional athletes to diagnose spring ligament tears, fluid will come out of here. If there's fluid in that joint and there's no tear, it'll be contained. But if this ligament tears or stretches, the talus migrates this way. It's called a hindfoot valgus deformity. And you often see it where it's all just down here, almost sitting beside the calcaneus instead of up above at this angle. So at least 3 cuts, you can see the spring ligament on the coronals. You can do the same on the axials. Here's the same patient, Tom, Dick, Harry. just under Tom is this band of tissue running like this, and this is the vertical portion, if you will, run down underneath the head of the talus. Here's another normal, 3 coronal cuts. Tom, Dick, Harry. Here's the spring ligament just underneath the posterior tib. Next cut forward. Here's posterior tib's got a little bit of fluid around it, enabling us to distinguish it from the spring ligament. And the next cut, again, the fluid around in the tendon sheath of the posterior tib helps us to identify the normal spring ligament. And this one is inserting nicely on here, and you can see a little bit of fluid. This is the talonavicular joint, runs down to here if you injected it there. Again, this restrains the talus from going in this direction, the so-called hindfoot valgus deformity. Same specimen on axials. Find the posterior tib, which is here. Tom, Dick, Harry. And this kind of signal in the flexor doesn't bother me a bit. Neither does that signal. That's not tenosynovitis. But there's the spring ligament just deep to it. Uniform low-end signal. Here it is more distally. Uniform low-end signal. It often has variation in thickness down here. So that's not thin attenuation. This is not thickening and scarring, but that takes a little getting used to. There's a wonderful article by Mingiardi some years ago in radiology, looked at 78 asymptomatic subjects. Now this has to be in Europe, and it is. Why 78 asymptomatic? I mean, at Duke we would have looked at 5, and gotten all of our data from that. We're not scientists. The beauty of this article, and he measured the spring ligament in multiple different places. It's a great article if you want to know about the spring ligament, and he showed that there are in fact 3 parts to the spring ligament. I and the surgeons kind of think of it just as a big J loop of tissue holding up the head of the talus like a sling. And I look at the coronal and I see it coming down medially and then curving under the talus. And that's simplistic, but it's not anatomically accurate. If you want to know more about it, and you don't need to, you can look at this article and see these different parts. Beautiful diagrams, beautiful article. To me, some of the strength of this article is in these 78 asymptomatic subjects, not a single one had any intermediate or high signal in the spring ligament. Now, we've used that for years to indicate pathology. This just confirms the spring ligament on T2 weighted imaging and proton density, or T1, will be low signal throughout. And I think that's an important point. Here's one where the posterior tib is split. The spring ligament deep to it, I can't even see it. Here's the spring ligament tattered. And look how thick it is here with signal in it here and thin back here. Now the thinning may just be normal, but the signal in it we know is abnormal, and that's abnormal. Here's one where there's a split tear of the posterior tib. The spring ligament is too thick, got signal in it here. Fat in the sinus tarsi is obliterated, and the patient had plantar fasciitis. Here's the plantar fascia with fluid underneath it and thickening within it. It's not unusual for the same patient to have posterior tib, spring ligament, sinus tarsi, and plantar fasciitis. As far as spring ligament tears, our fellow wrote this up, put it in AJR, did a great job. We ended up with 14 patients with surgical proof of torn spring ligaments. The things we found were an abnormal caliber, either thick or attenuated, just purely subjective, 93%. But this is key, and this was before we knew about Mingiardi's article. Abnormal T2 signal, every single case. Now, it wasn't fluid bright. It was usually just intermediate or gray, but that's abnormal. You don't have to call a tear when you see that, and we don't do that to this day. The only thing that's specific is a gap. We only saw a gap in 11 of the 14. Wavy ligament, that's a pretty good sign when you see it. And posterior tib was abnormal, not necessarily torn, in 13 of the 14. Not torn in every case, though. You can have isolated spring ligament tears. Here's such an example. The part of the spring ligament that I used to look at routinely, it's actually only a very small part. I think it's called the inferior plantar oblique portion in Mingiardi's article. This part that goes right here on the sagittal, between the tubercle of the navicular to the sustentaculum talus. And it's this tissue here. In this case, it's a gap, and you can see it's flopped up back here. Here you can see there's probably a little piece of cortex gone, but we couldn't see that on the plain films. But there is a little retraction. This is a torn spring ligament. And look at this contusion. This is somebody who slipped on ice, on concrete, and his foot, the arch just kind of flattened out, and the surgeons feel he banged the talus against the concrete. And I'm thinking, come on, no way. No way. Well, in fact, way. It's pretty close, isn't it? If this goes down here a little bit, it could very easily be impacting on the concrete with just skin covering it. In this case, spring ligament's disrupted all along here, all that's abnormal. There's no real normal spring ligament here. And you can see how this could easily go into a hindfoot valgus without a spring ligament. I think it's, in this case, best seen on the axials. Here's posterior tib. Here's the spring ligament looking like a baseball bat. That's the barrel of the bat. Look at all that signal within it. The next cut, here's the barrel of the bat. It's separated from the handle. A big gap here. Here's posterior tib. So this is an isolated spring ligament tear. They do occur. Get used to looking at the spring ligament because I can guarantee you, you'll see abnormalities routinely associated with posterior tibial tendon abnormalities. Here's a spring ligament that is way too thick, much too much signal in it. Look at all this. And on the axial as well. It goes up here, and then there's a gap up here. Posterior tib, when it goes and inserts onto the navicular, can give symptoms of a posterior tibial tear if you have an os navicularis, so-called type 2. And that's where you have a synchondrosis across here, which is not uncommon. 5 to 10% of the population will have that. But in some cases, this is loose, and you'll get these irregular articular surfaces here. It's not really articular. It's a synchondrosis, and you can see fluid signal on this one. Those are signs that this is likely mobile. We look on the sagittals. Here's the posterior tib coming down on T1. It attaches here. Here's that synchondrosis. And look at the irregularity of this surface, which is fluid-like with subchondral cyst on T2. These are the rest of the fibers of the posterior tib going underneath to make up the longitudinal arch. This can be, again, very symptomatic, can present with a painful flat foot, can have symptoms just like a torn posterior tib, and sometimes they have pain right here as well. Easy fix, and it's not uncommon for them to do that. They go in and remove this and reattach the posterior tib onto the remaining navicular. It's called a Kidner procedure. When we see this on plain films, we don't even mention it. Our surgeon said, please don't bother us mentioning every secondary ossification center in the foot, your os trigonum, your os peroneus, os navicularis, there's 20 of them. You could have 2 pages of normal findings. They haven't got time to read that. So I don't mention these unless I can see that it's fragmented, sclerotic, irregular, things like that might be clinically significant. In this case, a sagittal image, you can see the synchondrosis looks smooth. However, on the T2, it's got fluid in it and a little edema on each side, suggesting this, in fact, is freely movable and accounting for the pain this patient had. Same patient, here's the T1, here's the T2. So os naviculari certainly can be a source of pain that can very much mimic that of a posterior tibial tendon abnormality. Turning to the peroneal tendons, they run in a common tendon sheath, can have tenosynovitis, and sometimes that's all I see, but it has to be a fair amount of fluid before I will mention tenosynovitis. When I see fluid around the peroneals, as I mentioned earlier, it really makes me look closely at the underlying tendons because you just don't get tenosynovitis here without tendon abnormalities very often. I mentioned how they can be entrapped in fractures. We see that more frequently on CTs. Just remember to look at your soft tissue windows. They can dislocate. They're held in place here by a superior retinaculum or distally by an inferior retinaculum. If that tears, they can dislocate, and the surgeons have to surgically reconstruct that retinaculum, put them on here, sometimes accompany it with an osteotomy. Longitudinal split tears of the brevis, one of the common causes of chronic lateral ankle pain that Emily will touch on. And then POPS, painful os peroneus syndrome. Peroneus brevis comes down here, inserts onto the base of the fifth. Peroneus longus comes down with it, and then goes down to the cuboid, where it goes under the cuboid, through the cuboid tunnel, little groove on the bottom of the cuboid, over to the base of the first metatarsal. Right before it enters the cuboid tunnel, about 10% or so have some people say 20%, have a sesamoid, the os peroneus. And that's a stress riser, so that it sets up forces across it that can be painful and can result in a tear right at that point. And it's been termed in the orthopedic literature POPS, painful os peroneus syndrome. Something we found with the peroneus longus, as you follow it down, it's nicely seen on coronals. Here's the brevis, here's the longus, brevis, I don't see the longus. Here it is, back over here now. So is it torn? In about 15 to 20% of cases, the peroneus longus will disappear from your view. And we just have published this. It hasn't come out yet, but look at this. Here, longus brevis, longus brevis. As I go down, the longus is gone. Brevis, longus is gone. And we called a number of torn peroneus longus. And what else are you going to call it? It's gone, and there's a gap. And there was no fluid around them. They're asymptomatic. And in one or two, our surgeons were over here looking at the brevis or something on the lateral side, and they examined surgically the longus and said, no, it was perfectly normal. You guys were overcalling it. So we took some cadavers, imaged them. First of all, we imaged patients. We found about 20% of the patients had this pseudo tear of the peroneus longus. Imaged some cadavers. And those that had it, we then dissected them and found there's a fibrocartilaginous node in there. If you don't have an os peroneus, this fibrocartilaginous node will have no low T2 signal like the normal tendon does. It'll make it look like it's gone. Now, the other place that's been described is where the posterior tib inserts onto the tubercle of the navicular. And I'm sure you've all seen that. It kind of gets a little fat and it gets gray. And we've learned, don't call partial tears or tendinosis right there at that insertion onto the navicular, because there's a fibrocartilaginous node that seems to be trying to be the os naviculare, but didn't make it. So if you notice that the peroneus longus is gone, the way we handle it is we'll say on several of these images, the peroneus longus is not seen. This may represent a pseudo tear, but close clinical correlation is recommended. If I see fluid signal around it, if I see edema in the underlying calcaneus, that's different. I'll go ahead and call those. But this is not uncommon. Tibialis anterior, the main dorsal flexure of the foot. A lot of different reasons to get it, mostly athletic in nature. Rupture is uncommon. Again, we see 2 or 3 a year, and they already know it clinically. They're trying to see how big is the gap. Here's one where you got diffuse swelling. It's easy to say, oh, look at here, it's so thin and attenuated, but that's just running out of the view. That was perfectly normal, in fact. The abnormality was up here. And there wasn't a real gap at all. It was just kind of shredded. You can see no normal tendon right through this area. But it's important to show them the gap. On this one, here's a distended tendon sheath. There's just a string of tissue in there. Here it is on the T1s. On the T2s, the gap was of just about from here to here, but that's confirmed on the axials, not just on the sagittals, for the reasons I mentioned. The patient was thought to have a navicular stress fracture. There's 3 stress fractures that are just absolutely severe for athletes. One's going to be in the femoral neck, one's going to be in the tibial, anterior tibial, and the other is going to be in the tarsal navicular. And our surgeons and sports medicine docs pay particular attention to those. This was thought to be just that, but the navicular, in fact, looks pretty good. Now, we have had a couple of cases where we couldn't see anything but some reactive edema on MR, but they really want to know is there a cortical break, and we've gotten CT, and it shows a cortical break that even in retrospect we didn't see on MR. 10 years ago, I'd never had a case where CT showed a fracture and MR didn't also. So we could just do MR. The reason CT shows it nowadays is the ultra-thin sections they get over MR. So if we have just reactive changes in the marrow and they're worried about a fracture in one of these real sensitive areas, we'll go ahead and sometimes then follow with a CT. Why don't we start with a CT? Because other things can mimic those fractures that CT wouldn't show you, such as this. In this case, there's a partial tear of the tibialis anterior tendon. Look at all this fraying, morphologic change through here. And it runs right over the tarsal navicular, and it's coursed down to the great toe. We've got half a dozen cases of tibialis anterior abnormalities that either partial tears or tenosynovitis that they thought were stress fractures of the navicular. I think we tried to write up 3 or 4 of these some years ago and didn't get it finished. Part of it, we didn't have surgical proof. One of them had partial tear. They continued their activities, went on to a complete tear. But they thought that they clinically represented navicular fractures when they weren't. Flexor hallucis, rupture is very uncommon, even less common than tibialis anterior. You can get tenosynovitis. In fact, in New York, most of the articles were written here from the New York Ballet Group that that had tenosynovitis and pain. It's called the Achilles of the foot for dancers. So it kind of has a reciprocal function with the Achilles. Marked plantar flexion, toe standing, jumping also, basketball player, volleyball players, but particularly ballet dancers. Before you call tenosynovitis though, check the joint itself to see if there's a big joint effusion, because the flexor hallucis communicates with the joint in 20% of the cases. In the shoulder, the biceps tendon sheath, it communicates with the shoulder 100% of cases. If you've got a lot of fluid in the biceps, we know that it communicates with the joint, probably just represents a joint distension, a joint effusion. Some people say if it's markedly distended, out of proportion to that in the shoulder, you can cause biceps tenosynovitis, and they apply the same thing here. I don't have any good evidence that that is in fact valid, but just remember it does communicate with the joint. You can get compensatory stress when you have Achilles injury, and there are some other associated abnormalities with the flexor hallucis that can cause this posterior impingement, as it's called, or posterior ankle pain that I'll talk about. Here we've got Tom, Dick, and Harry. Tom, Dick, and looks a little weird, but it's okay. Tom, Dick, no Harry. And that's because it's torn and retracted. You just don't see this very often, though. I might have seen 4 ever. Here it is on coronals. It's torn and retracted up to here. Here it is here. On the sagittals, this turned out to be the gap, here to here. But again, that's not common. This is a professional basketball player. Looks like he's got an abnormality with his Achilles, but in fact, this is post-op. And when you have a post-op change, whether it's Achilles, rotator cuff, or whatever you already know, there's not much I'm going to be able to tell them except for a big gap. And there's no big gap here. So these could all just be thickening and surgical, post-surgical changes. But likely his pain is from this tenosynovitis of the flexor hallucis. All is fluid. It doesn't have a joint effusion. It has isolated flexor hallucis tenosynovitis. And it's likely because this was a weak Achilles still recovering from his surgery, and he's overcompensating with the flexor hallucis. You'll sometimes see a lot of signal in the tendon sheath with irregular borders like this. Almost looks like hostra. Little indentations. And this is one of the few tendons that can set up a trigger phenomena. It's called a trigger toe. This is stenosing tenosynovitis. And these little hostra evidently kind of impede the motion. It's an easy clinical diagnosis because they take the big toe, just like trigger thumb with Dacre veins. They take the big toe and they can move it, and then all of a sudden it gives the trigger. And it's painful. And they can certainly trace it back to the flexor hallucis. So stenosing tenosynovitis, we'll mention that anytime we see irregularities rather than a smooth wall tendon sheath. Something else that's associated with flexor hallucis tenosynovitis is ostrigonum syndrome. This is fairly commonly seen. Our surgeons operate on this fairly frequently. They get pain in the posterior joint, so-called posterior impingement. Results from impingement, actually, recurrent forced plantar flexion. You get the ostrigonum kind of squeezed between the tibia and the calcaneus, kind of nutcrackered in there with plantar flexion. In this case, the ostrigonum is kind of low in signal. It ought to be fatty marrow like the rest of this, and that's just a bone island. On the T2s, you can see the signal within it, a little cystic change, and again, like the os navicularis, synchondrosis has high signal. It should be low signal fibrous tissue in that synchondrosis. Same in the shoulder, the osteocromial. When you have fluid signal through there, I will usually report that. Let them match it up clinically, even if they didn't come in for that. Certainly if I have edema in the ostrigonum. And in this case, there's a little bit of distension of tenosynovitis at the flexor hallucis as well. Ostrigonum doesn't look too bad on T1, but look on the T2. Look at the associated edema in the calcaneus. Look at the synchondrosis with high signal, edema within it, and the soft tissues are all edematous as this gets squeezed with plantar flexion. On the axials, here it is. Look how irregular that synchondrosis is, and look at the fluid across here. What do they do for this? They go in laterally, remove this, cut this posterior talofibrillar ligament, which comes out of the malleolar fossa and attaches to this. And they don't reconstruct it because the posterior talofibrillar ligament doesn't seem to give added stability to the lateral ankle joint. We'll talk about ligament shortly, and we'll primarily talk about the anterior talofibular ligament, which you should see in every single ankle at the malleolar fossa. It makes up the anterior joint capsule. If there's any fluid in the joint at all, it'll be bound by that. I have never seen a torn posterior talofibular ligament. 2 large series in the ortho literature talking about lateral ligament reconstructions. About 200 patients total that don't mention a single torn posterior talofibular ligament. So what I'm telling you is you don't need to look at the posterior talofibular ligament. Don't get excited because it's got a little signal like this that might represent a partial tear or sprain. The surgeons don't see tears here either. About 5 years ago, maybe 10 now, we had a top golfer on the Duke golf team. She won the NCAA championship her junior year. She's now playing professionally. Stepped in a hole, tore lateral ankles. We did an MR. We had a torn anterior talofib, calcaneal fib, and the dreaded high ankle sprain, the anterior tib fib ligament. We'll go over these in a moment. Surgeon calls me from the OR. Now this is a surgeon, he's got a little bit of an edge to him, and you want that. You know, you're a fighter pilot, you're a surgeon, and he'd told me in conference several times, I think I read these MRs about as well as you do. I said, I think I could probably do surgery as well as you do. That wasn't true, and he probably could read them close to the way I do, but nevertheless, I was trying to needle him back. Well, he calls me from the OR. He said, you remember so-and-so? I said, oh yeah, the ankle ligaments, how'd it go? I said, fine, but you missed that torn posterior talofibular ligament. I said, well, you read these about as well as I do. You missed it too, didn't you? He didn't want to hear that. He said, well, let's look at it in conference. We looked at it in conference. You couldn't tell. It looked just like every other talofibular ligament. I said, well, what'd you do? He said, well, I reconstructed it. I said, why? He said, it was torn, like dummy. I said, have you ever done that before? He said, no, it's the first one in 25 years, only torn posterior talofib he's ever seen. I said, well, if it had been an osteotrigonum, you would have cut the ligament. You don't suture it back on to the calcaneus. Why did you do that? He said, no, I know. I thought about it. I don't know. Probably didn't need to. The point is, if you're looking at the posterior talofibular ligament, you're wasting time. You're not going to see one torn. Here's one where osteotrigonum's got signal around it. It's got fluid signal in the synchondrosis. That's clearly abnormal. We look on the axials, here it is, and look what's sitting right next to it, the flexor hallucis. And the flexor hallucis can rub across these uneven edges. If this is in motion, this can then go onto a partial tear. And in this case, look at the next cut, flexor hallucis here, and here it is, a partial tear. At conference, the surgeon said, are you sure it's torn? I said, well, it sure looks like it. When you're in there, you tell me. He said, no, I won't know. Because normally, we go in laterally and take out the osteotrigonum. We can't even see, can't get good visualization of the flexor hallucis. If the flexor hallucis is torn or abnormal, they have to go in medially. And they don't like to because the neurovascular structures here increases their complication rate. On this one, he went in medially. He did, in fact, find a partial tear of the flexor hallucis, which he repaired. Another cause of posterior ankle pain can be thickening of the intermalleolar ligament. A normal structure back here, seen in about 80% of cases, runs between the medial and lateral malleoli. This is the normal tib fib, posterior tib fib. It doesn't tear very often, but it does tear on occasion. Here's the posterior talofibular ligament, which never tears. And you'll see these, the nice advantage on your coronal images, posterior cuts, which is unfortunate because none of them ever really have much pathology. This is a normal structure. We described 3 patients, however, where it was thickened because of squeezing back here, just like the osteotrigonum, with marked plantar flexion. This is the posterior tib fib ligament. You'll see it every time. I've called a few of those loose bodies before I learned that no, that's the normal posterior tib fib ligament. This is the intermalleolar ligament. Posterior talofib will go on to the osteotrigonum or the posterior process of the talus. But that's bigger in size than the tib fib. That's a thickened intermalleolar ligament. And it can result in posterior impingement and decreased motion. These were outside images sent to us with a patient who was a professional soccer player. Played on the World Cup team for the U.S. More than any other World Cup player. Was having decreased ability to plantar flex, and he was kicking hundreds and hundreds of balls a day with plantar flexion. He was having posterior pain with it. And you can look at his posterior intermalleolar ligament here. Look how thick it is. Over here it looks okay. it's smaller or the same size as the tib fib, but it got markedly thicker over here. Here it is on the axials. And at surgery, they removed this thick meniscoid tissue that was a thickened intermalleolar ligament. Right there on the table, they said he increased his range of motion. Within a few months, he was back playing for the U.S. team, pain-free. This is a ballet dancer. You can see on the coronals this thick intermalleolar ligament, and you can see it here on the sagittals. This, in fact, was removed with resolution of symptoms. There are a few masses that are unique to the foot and ankle. Actually, I said I was going to speak about ligaments, though I will not speak about them. Emily's going to talk about ligaments. So we will skip to tumors or masses that are unique to foot and ankle. I may or may not reiterate one or two of these in my mass talk, but this is one that we see not infrequently in the foot and ankle. Obviously an old image with both ankles in the field of view. Look how thin this one is, and look how fat this one is. The patient can feel this, says she thinks it's getting bigger. Now it's maybe a little achy or sore because she's pushing on it, and they want a biopsy. But this stays with muscle on T1 and T2. This is peroneus cortis. This is an anomalous muscle commonly seen over here with the peroneal tendons. You can also have a low-lying belly of the brevis, but it typically won't cause this kind of bulge. This is one where, look how big this ankle is compared to this one. This is an accessory soleus, standard T2. This is not a tumor. And you'll see accessory soleus not uncommonly. This patient has plantar paresthesias and burning. Put the marker over a little mass that they could feel, and it's painful there as well. It looks like it's just fluid, just a little ganglion. It's between Tom, Dick, and Harry. It's where the neurovascular bundle runs. And if there's a mass in here, whether it's fluid or a tumor, it can push on posterior tibial nerve, setting up this plantar burning paresthesias. It's called tarsal tunnel syndrome. Now, this may look like fluid, but there are a couple of solid masses that can have the same appearance, and we see these not infrequently. Those are neurogenic tumors, schwannomas, benign or malignant, neurofibromas, and others. And there's synovial sarcoma. And synovial sarcoma is the most common sarcoma in the foot and ankle. And while they're usually large, as most sarcomas are greater than 5 millimeters, or 5 centimeters, in the foot and ankle and in the hands where there's thinner tissue, they can present as very small masses. So when you see what looks like a fluid collection in this region, you need to give gadolinium or do ultrasound, confirm that it's solid versus cystic. This turned out to be a ganglion, which is one of the more common causes of tarsal tunnel syndrome. So it's secondary to this tibial nerve entrapment, or rather than entrapment, probably impression. This is a tight compartment. You can set up like a compartment syndrome almost. It doesn't have to actually touch the nerve. Most common causes are neural tumors, which could look just like that ganglion, and ganglia. And then idiopathic. Now, in the carpus, nobody images for carpal tunnel syndrome. We did for a while. There were measurements you could make, there were signs and so forth. It never changed what they did. They go in and they cut the flexor retinaculum. They move the tendons aside, the flexor tendons, and see if there's a lipoma, ganglion, a mass of some kind. We image them nowadays, and you do too, when carpal release fails to be curative, and they want to know, is there something else in there? Is there scar tissue? Whatever. So the post-op cases. Well, in tarsal tunnel syndrome, there is a flexor retinaculum, but they found if they just, for idiopathic cases, go in and do a retinacular release, it scars down and often makes it worse. So they don't like to operate unless they can see a definite mass. Otherwise, they're reluctant to do that. So non-operative treatment typically if it's idiopathic. So we get MR to look for a mass. This is an older article in orthopedic literature, 50 cases of tarsal tunnel syndrome, and there are probably 50 different causes of tarsal tunnel syndrome that have been published, anomalous muscles and so on. But in his series, a ganglion was 36%, a tumor, neurogenic tumor in each case, 6%, tarsal coalition, which I'd not heard of before, with hypertrophy of that middle beak, crowding the tarsal tunnel. He had that in a third. And then a quarter to a third were idiopathic or post-traumatic, which in today's world likely would not have surgery. Our surgeons say one of the more common causes they see are varices, large veins, but lots of things have been described to cause tarsal tunnel syndrome. The most common, though, seem to be ganglion, tumor, and then idiopathic. In this example, I've got a large mass here medially that on T2 looks like fluid, on coronal looks like fluid. This is one you need to give gadolinium for. A solid tumor could have the same exact appearance, and we see that all the time. This was a ganglion. Here's one the former fellow gave me. Got a mass here, looks like fluid. They gave gadolinium, but unfortunately, they fat suppressed the gadolinium, the T1 after gadolinium. They're comparing this with a T1 before gadolinium. So they've changed two variables. They've fat suppressed it, and they've given gadolinium. And they're going to assume if this mass gets bright, fortunately it didn't, they're going to assume it's from gadolinium enhancement, it's a solid mass. And we've been fooled on that many times. At our Tuesday tumor conference, I told you we have 12 tumors every week. Half of them come with outside imaging. 90% of the time, they have gadolinium. You don't need gadolinium for tumors. You need it to tell solid from cystic. But most tumors, you can tell just by looking at the T1 and T2, this is not fluid, this is a solid mass. Gadolinium enhancement is not going to help you. 90% of those with gadolinium have fat suppression after the gadolinium compared with non-fat suppressed pre. Now, if you want to do fat suppression, that's fine, but you got to fat suppress your initial one, which will lengthen your study, because for tumors, you got to have a non-fat suppressed T1 of some kind. These are prettier images, but you'll be able to tell if it enhances or not without fat suppression. I'll touch again on that when I go over masses on Sunday. In this case, this one didn't enhance, so we're safe in saying, even though it's fat suppressed, that this is fluid. But if it did enhance, we still wouldn't know. It could be that it seemingly enhanced or got brighter, but it was because of the effect of fat suppression. How about this one? A mass medially. This sure looks like fluid, but again, it doesn't have to be. This turns out to be a schwannoma. Notice also abductor digiti minimi, the atrophy. It's because this is pushing on Baxter's nerve. And if Baxter's nerve is irritated, it can set up plantar, burning, and paresthesias, just like tarsal tunnel syndrome from anything, and you'll get atrophy of the abductor digiti minimi. Put that in your search pattern. You'll see this a lot. And in fact, a couple of articles found in asymptomatics in 5 to 10% of MRs. One of these was 5%, the other was 10%. We see this all the time. So our fellows say, we see it all the time. I'm not even mentioning it. Wait a minute. We see disc protrusions all the time too in asymptomatics. Up to a third of the patients over 40 have disc protrusions. And they can be symptomatic or asymptomatic, but they can also be symptomatic and require treatment. So our job is not to tell them if this is symptomatic or not. Our job as radiologists is to tell them that there is atrophy of the abductor digiti minimi. Let them decide if it's symptomatic or not. Let them earn their money. It's been shown that you have an increased incidence if you have calcaneal spurs and plantar fasciitis, and that's because Baxter's nerve, the first branch of the lateral plantar nerve, runs right by that calcaneal spur. And in fact, for plantar fasciitis, you'd think heel pain, they'll go in and they'll take out that spur. They don't touch it because they know they have a high incidence of injuring Baxter's nerve, setting up long-term burning and plantar paresthesias. So they try to leave this alone. A tumor type process that we see not infrequently in the foot and ankle is this. Here's a flexor hallucis tendon sheath, grossly distended with all this low signal lining the tendon sheath. Here it is on axials. Looks like a little magnet with little iron filings. You guys aren't old enough to remember iron filings. You'd go down to the toy store and get a little magnet with iron filings as kids and play with that, and they look just like this. Nowadays, it's guns and condoms, but they're having more fun than I had. But anyway, these are iron filings. This is hemosiderin deposits, and it is pathognomonic of giant cell tumor tendon sheath, and is not uncommon in the foot and ankle. Another example, a mass emanating from the tibio-talar joint because we got it in back and in front. It's also going down to the sinus tarsi. On T2, look at all this low signal. This is pathognomonic In this case, it's not in the tendon sheath. It's not giant cell tumor tendon sheath, so this is pigmented villonodular synovitis. They're the same thing. One's in a tendon sheath, one's in the joint. And these are not uncommon. Same patient on the axials. Look at it coming out of the joint, all out of the joint. But wait a minute. Oh, here it is in the flexor hallucis. Distending that sheath, lining the tendon sheath. Well, 20% of cases, don't forget, the flexor hallucis communicates with the joint. So that's an easy access from the joint into the tendon sheath. But wait a minute. That's the peroneal tendons. And it's got it as well. Is this multicentric, multifocal, giant cell tumor tendon sheath? What's going on? That's not been described. Well, we surmised that the closest place for the peroneal tendons to get to the joint is down there at the calcaneal fibular ligament. It's right there at the joint. And sure enough, at surgery, he found an aperture between the joint and the peroneal tendon sheath right at the calcaneal fibular ligament, allowing this to involve that tendon sheath. What they do for this is they just try to debride as much of this as they can. It's got obviously a high recurrence rate because they can't get all of it. On this one, I've got what looks like a ganglion adjacent to the navicular. It enhanced with gadolinium. This was a solid tumor. This was synovial sarcoma. They can look just like ganglia. 30-year-old with swelling. It's got this mass, looks like it's coming right out of the ankle. It's got even some septations. This has got to be an atypical fluid collection. And whenever we say atypical fluid collection, whether it's a knee, shoulder, whatever, a red flag goes up that, hey, maybe we better give gadolinium. What we do is we give the caveat. Although this has the appearance of an atypical ganglion or synovial fluid collection, a solid tumor can't be completely excluded. Recommend close clinical correlation or ultrasound or repeat with gadolinium to make sure it's not a solid tumor. And this turned out to be a benign peripheral nerve sheath tumor. It's not coming out of the joint, not going into the joint. This was just some joint fluid, and it was the joint capsule is probably out here somewhere, and it's like two water balloons pressing against one another. You can't separate them. This is virtually pathognomonic, and they use MR for this. Got a mass in the plantar aspect of the foot that's low on T1 and on T2. It's associated right up against the plantar fascia. This is plantar fibromatosis. The reason they use MR because they don't want to biopsy it, and they don't surgically remove this. The 3 rules for plantar fibromatosis are: number 1, don't operate. Number 2 and number 3 are just like number 1. They don't want to operate because they'll have this patient back in every 6 months carving away at this. The patient's unhappy. It never heals. So they'll, even when they're large like this, and they're usually not, they're usually more like this, BB size or P size, and they can feel them and they're painful, but they'll put some padding, orthotics, whatever, anything except to try to operate on them. They'll avoid surgery. They invariably have a bad outcome. Now, what is this? This is basically a desmoid tumor. I'll go back to this one. This one had to start out small, and it's getting bigger. But these, unlike desmoids elsewhere, don't seem to spread and extend into other areas and cause problems. They can be lethal, even though they're benign tumors. If they get up into the retroperitoneum, they get into the thorax or the neck. And if they start up in the ankle, and they can start any soft tissues anywhere, they can, in fact, go up to the knee, up to the groin, into the pelvis. And we used to see amputations for this all the time. I've seen them where they had ankle amputations right at the ankle, then they do a BK, then they do an AK, and then they find out they're still behind it. It's gotten up into the pelvis. Nowadays, they treat them with radiation, and there's chemo also. And I've not seen an amputation for one of these in maybe 5 or 6 years. But those are desmoids elsewhere. Desmoids in the foot and ankle, or on the plantar fascia rather, don't spread. Never been reported to my knowledge. Again, this is the more typical type, and I'm not sure I'd even see it if they didn't mark it, because they're low on T2, not real conspicuous sometimes on T1s. You'll see what looks like a mass often in this location or under the head of the metatarsals, and it's just under the medial tubercle calcaneus. It's kind of indistinct, but sometimes it's a little more mass-like than you're comfortable with, and you'll wonder, is that plantar fascia, or plantar fibromatosis rather, coming off the plantar fascia? Well, this is a pressure lesion. It's from, as the name implies, just pressure, walking. These are not painful. I've never seen one come in where they say, I feel a mass and it's painful. We see them because we're looking at something else, and then we see this and go, oh my goodness, what is that? And that's a pressure lesion, and you'll see them in half your cases, guarantee it. As far as a few bony abnormalities, this is a woman who had a pneumonectomy for lung CA. She's got heel pain. They wanted to do radiation, but the radiation oncologists were reluctant, as you can imagine, and said, no, we need some tissue. So they wanted a biopsy. We didn't feel like we knew where to biopsy, so we get some more imaging. Bone scan's not helpful. It's not a tumor at all. Radiation wouldn't have done a lot for this. This turns out to be an insufficiency fracture. Obviously, she was worried about recurrent tumor. Axial shows the typical fracture. One of the fellows saw this and asked me, said, I've got some sclerosis here, linear sclerosis. Is that a calcaneal stress fracture? No. Calcaneal stress fractures occur here. This is the classic calcaneal stress fracture. Well, he did what we're supposed to. You don't have to know what everything is, but you do have to describe it. And I'm sure you've all been through this. Early in my career, if I didn't know what it was, I wouldn't mention it. And I had a lot of those come back and bite me, and you can't do that. Unfortunately, they didn't have attorneys attached to them. So he mentioned some linear sclerosis of undetermined etiology and significance. And as I get older, I find myself saying that phrase more and more and more. And of course, it's a stress fracture. And he didn't gloat a whole lot, but since then, I've seen about 4 with its exact location. And you know, it doesn't matter where it's at. If you've got linear low signal, that's a fracture. Here's one, the more classic type, parallel to the posterior calcaneus. MR did not need to be done. We'll sometimes see the fracture line better on T1 than T2s, or vice versa. But you need to see the fracture line rather than just edema. But again, if you got this on a plain film, you're done. As far as AVN, foot and ankle is not an uncommon place to have some, whether it's diffuse or focal. It's good for detecting it when plain films don't show it. Good for showing the extent. It's somewhat useful for saying if it's focal, an osteochondral lesion, is it stable or unstable? We're not very good at loose bodies. Here's one where the tarsal navicular's got low signal throughout. If it's low signal on T1 and low on T2, we've had pretty good luck just saying that's dead bone. If it's low on T1 and bright on T2, it may go on to be dead. This may just be fibrous tissue and a bag of dead cells, but it also could be viable tissue. And these are the ones where they like to do a core decompression to decrease intraosseous pressure. They like to do maybe a pedicle graft, arterial anastomosis, that kind of thing. A lot of different ways to treat it. But at least there's hope. Whereas when it's low on T2, that's typically too late. Here's one where it looks like diffuse low signal. It's bright on T2. This was an athlete, basketball player. But don't forget to look at all the images. And in this one, look at the fracture. And that's a classic location for a fracture. And they'll put a cannulated screw through these. Whereas if it's just edema without a fracture, they won't. So it's important to see that fracture line. And obviously, they wouldn't put a screw in it if they thought it was AVN. Here's one where we've got, again, a basketball player, got a little bit of edema, pain in the tarsal navicular. Looks like some sclerosis, excess bone here, which may or may not be physiologic. But the MR shows a definite cortical break here. CT was obtained but didn't need to be. CT shows the same thing. Nowadays, though, as I mentioned, because of the ability to do really thin section cuts, you'll occasionally see a fracture, a cortical break on CT that you don't on MR. All you see is reactive change. Once you see the cortical break, though, you're done. We like to image both ankles, but not at the same time or in the same coil if they're worried about tarsal coalition. Tarsal coalition, to me, is best seen as just looks like degenerative disease, usually the middle facet like this. You can see it here. And I'll sometimes end up saying this is either tarsal coalition, most are fibrous or cartilaginous, not bony. And I often will say this is a coalition or subtalar degenerative disease. Now, when you have this angle oblique like this rather than straight across, and it's hypertrophied like this, that's an easy call of tarsal coalition. If I only had this one, I wouldn't know if that's degenerative disease, post-traumatic, or coalition. But this one makes it easy, and over 50% of the time it's bilateral. The way to do it is study them individually. Look at this angle. Instead of going across, this middle facet is obliqued way down like this. It's hypertrophied. It looks like degenerative disease again. And in addition, a big talar beak, all the things we think of with tarsal coalition, and it's bilateral. On this one, this is horizontal, but it looks irregular. If I just had this one, I wouldn't know if it's degenerative disease or coalition. This one is starting to slope down, and it's getting this hypertrophy. That plus the talar beak, I would call this coalition, even without the other ankle. Finish up with just a few miscellaneous things. This patient's got plantar fasciitis. It was bilateral, but it's better in the other foot now, and it's better because it's gone on to a complete tear. In fact, if they operate on these, and they usually don't, but if they do, they go ahead and cut it completely, like doing a biceps tenotomy. And that relieves their pain, but it sets up some mechanical problems in the ankle that we won't go into, that they really like to have this intact. You're looking for thickening, you're looking for edema in the soft tissues and the adjacent bone, and it almost always occurs in the medial tubercle, the medial band, rather, of the fascia that goes to the medial tubercle. And here's the edema. The lateral band's perfectly normal in this case. Here's another one where it's pretty good over here. The other side doesn't hurt as much anymore, and that's because it's gone to a complete tear with retraction. Again, Baxter's nerve runs right by here, and these patients with plantar fasciitis have a high incidence of irritating that nerve, ending up with abductor digiti minimi fatty infiltration. The plantar plate can be a real debilitating injury for an athlete. It's also called turf toe. And what we're looking for, and same in the fingers, where it's called the volar plate. You're looking at the thickening of the capsule on the plantar aspect of the metatarsal head and proximal phalanx. The flexor hallucis in the great toe, flexor hallucis longus runs through the middle. The brevis goes through each sesamoid, if they have sesamoids on each side, and they run through the capsule, making this thick fascial band that supports the joint. With a marked hyperextension of the first phalanx and a downward force that it's disrupted here, causing plantar plate disruption. And here's such an example on short axis imaging where instead of a band of tissue across here like we have at 2 and 3 and 4, it's disrupted here. Sesamoid is retracted over to the side. It's disrupted all along here. You can see it on the T1s as well as the T2s. Here's one where it's retracted. This is the sesamoid. It ought to have a band of tissue going up here. This is the medial sesamoid. Here's the lateral sesamoid, and you can see the gap right here and here. And that's typically where it tears, just distal to the sesamoid, anywhere along this point. And you can see all this tissue is now retracted up and looks fat. But there's a gap, and good surgical treatment for that. This is an all-pro wide receiver. Ended his career early because this was not picked up, and it resulted in a multi-million-dollar lawsuit that had the radiologist involved as well because he did not call this on MR. But look at this, this completely disrupted here and here. And when the MR was called normal, evidently, and I'm getting this from Sports Illustrated, so a real reliable source, they just injected this with xylocaine, put him back in the game, and then he just destroyed it completely and had to retire. This is a Duke basketball player from 2 years ago. And we imaged him preseason. He had what we thought was some stress injury over here preseason on his MR. We do MRs of the knees and feet on these basketball players, and sometimes pick up some things and heads off injuries down the road. It's been very successful in doing that. Even though it's expensive, they want us to continue it. And he had bipartite sesamoids, both medial and lateral sesamoids. In December, about 7 games into the season, he has an injury, and look how diastase they are compared to that. He's torn this synchondrosis. Now, you probably don't need an MR. You got your diagnosis right there. But as a basketball player, and they treat them like rock stars, you can see here's the bipartite sesamoids, distal, proximal, a big gap in between. Here's the flexor hallucis in between. Here's the medial sesamoid is diastased. These are rare for them to occur like this at the synchondrosis, and only a few ankle surgeons in the world had ever seen them. It was debated whether to have surgery or not. They finally elected not to have surgery, and he healed in time to come back for the NCAA championship or a tournament, and then went on to play professionally, where last year was Rookie of the Year. So this is not kept him from playing further, but severe injury can be debilitating and can take a long time to heal. This took months and months and months. This is the more typical. This is a Duke football player, and here it's torn distal to the sesamoids. Here's flexor hallucis, and here's going to be lateral. That gap is abnormal. So do thin section imaging. You need both coronal and axial or sagittal images, and you'll be able to see these. Finish with this. This is something we see not infrequently. And the spotted high signal, maybe diffuse throughout the talus. This is bilateral. Patient's incapacitated. Sudden onset of pain, no trauma. This is painful bone marrow edema syndrome. There's a really good review article by Karmpilis in Skeletal Radiology 3 years ago. Several other articles on this. In fact, Don Resnick had one of the first articles on it, called it Painful Bone Marrow Edema of the Talus. He had 5 patients, and in his article, he said multiple other bones throughout the foot and ankle also had edema that was patchy, but he was fixing on the talus, which often is the most profound edema. This is idiopathic. They have pain, soft tissue edema, self-limiting. In this article by Fernandez-Canton, 18 out of 25 resolved in a year. To me, the news here is 7 of these lasted more than a year. Bilateral and up to 25%. Look at this. Most of this is in fact in the talus in this patient, but it's scattered around throughout other areas with no other abnormality. Self-limiting. Nobody knows what it is. You can read one of those articles and see why it's probably not SUDEX, chronic regional pain syndrome. There's good reason to suspect it's not. Here's again a patchy edema in somebody with marked pain and an incapacitation, and another one. We see these all the time. And our surgeons are happy to see this because they send them to the pain clinic. They can't help them. I've seen these biopsied, and I don't know what it is. We just call it painful bone marrow edema syndrome. It occurs in the hip. That's idiopathic transient osteoporosis of the hip. Occurs in the knee, usually an entire condyle. We used to call it SONC or SPONC, spontaneous osteonecrosis. Don Resnick just mentioned it as being partly due to radial tears. Emily Vincent has been teaching me that she thinks that's correct. I think that is a trigger. But spontaneous onset, and often the meniscus is normal, clears in about 6 to 8 months. And it can occur in the knee, and then the ankle, and then the hip. And if it occurs in 2 of those places, it's called regional migratory osteoporosis. I don't know what it is, and it doesn't really matter what it is. If it's in the hip and the knee, our surgeons want a phone call so they can give that patient protected weight bearing, because they find if they don't, they'll go on to have subchondral insufficiency fractures and sometimes collapse in the knee. Haven't seen that in the hip. But the fractures you see in the hip. Same here. These patients, they just give them protected weight bearing. Palliative treatment. And this one, again, was bilateral. So in conclusion, MR of the ankle is increasingly requested, confirms and makes diagnoses often made not easily clinically. Surgery often is based on these MR findings. The anatomy is easily learned. Pathology is limited to just some of these areas that I just talked about, and actually it can be an easy exam to interpret. But I'll tell you, if I've got 5 minutes before conference and the fellow says, hey, can we just look at one more MR? If it's an elbow, no problem. Even a shoulder. If it's an ankle, I can't do that in 5 minutes. There's just too much to look at, and you got to get yourself a search pattern and look at all those things. But once you do that,